I was very disappointed on galleys from my article that just came out on COVID, kangaroo care during COVID, giving national guidelines for it. Because when they sent the galleys, there were 48 mistakes that were made in the galley, typos and punctuation, stuff like that. And I said, please add this last sentence because a study had just come out by Maskey saying that the benefits of kangaroo care are 64 to 645 fold the chances of dying of COVID-19 when doing kangaroo care. It's a risk assessment and 64 to 654 fold greater benefits than the risk of dying from COVID-19. So I really wanted that statement in the last sentence of the article, and they didn't want it. I'm disappointed, but I guess galleys is too late. They would have to send it back to the printing people, and the other corrections they can just make themselves. So I didn't get into that, but it's one of the things I want to mention today.
Susie, what happens with the conferences for the ink? You said there is one in Spain in 3 years, but what about next year or this year?
Well, we're hoping to get it going. In 2019, I had a total knee replacement on June 3rd, so I couldn't do the talks, and they didn't want to make it any later. Then 2020, we had to be remote, and we couldn't get it all together to do it remotely, especially when we really emphasized the skills lab so much. And we're still remote. We're not allowed back in our buildings and our offices where we wanted to have the meeting until September 1. So it's not on for this year. Like okay. Kathy Morgan and I were just talking yesterday about let's get it together for 2022. And we're looking at the first weekend in June as usual.
And the meeting in Spain?
Yes, the meeting in Spain is in Madrid in November 2023.
And nothing this year?
No, we
were every 2 years, right?
Well, yeah. So we were supposed to have it in 2020, and we were going to be going to Manila. But they had to cancel it because they don't have the capability to do it all remotely. And it's just too much for Suki, to get it together. So she then said she would do it in 2022. But I think that Natalie was talking with some people and thought 2022 may still be too early for many people to travel, especially with the variants coming out. And the hope for the new booster vaccine, which is supposed to be ready to handle all the variants August 1st, that's what we knew until last Friday when the notice came out on Medscape that would probably be delayed until January 2023 for the booster vaccine for all the variants. So I think with that information, I believe they've set it for 2023. I have a folder somewhere behind me in my files. Yeah, because we're planning the program now, and I've been asked again to do another workshop for the full-term infants. But I can send that to you, Yamil, when I get the exact. We don't have an exact month. We don't. It's going to be in Madrid. Kiki Palace is going to be arranging it. If you know her, she's delightful. So, yeah, I would probably go back to Kiki Palace.
Okay. You know that we have people registered from 13 countries.
For today?
Yeah.
Oh my, no, I did. That's wonderful. I did get your email where you showed it in the United Arab Emirates. That's delightful.
Yes.
I'm glad. It is. It's a worldwide phenomenon. It should be fantastic for every baby.
I know. It's definitely celebrated in a lot of places around the world.
Yeah. Okay, you wanted me to sit back. I noticed that you're sitting back, so maybe that's what I'm supposed to do. Sit back like this, okay?
Yeah, that's perfect. Can you see the screen though?
Yep. Well, yep. No, that's too far. I
Let
need,
me send, let me send the chat and see if you can.
oh, my mother would kill me. I'm using my silk blouse to clean my glasses. There. Now I can see the screen completely.
Can you see the chat?
It says from Zachy to everyone. Welcome, everyone. This is Susie Ludington. Glad to see you. Glad to have you here.
Great. We have 10 more minutes, but to start. I think I'm not sure. Okay, so many of the people that registered, they said that they cannot make it because it's in the middle of their work day, but they will see the screen, and they sent me some questions that I will be sending if we run out of questions.
Okay, well, then I think I
Questions, but
have time to check the date on the meeting. Hold on. I probably have it here. Okay, it's definitely in 2023 because I don't have anything down for 2022. So for sure, it's in 20.
I liked the conference in Colombia. Thought it was really good.
Isn't that wonderful? I really enjoyed that. We had so much fun there. I've been collecting all this American memorabilia. I must have 3 hats I'm going to wear, 4 bags I'm going to carry, 2 different shirts, different slacks, and shoes, and earrings, and a bracelet. My God, because I was unprepared last time. This time I'm going to really be prepared and have enough stuff for my sister Mary, who's going to join me because I will be retired by then. So.
Retired.
Yeah. Well, I just got a grant last week, so I have to do that grant, and that's going to take me a year, and then I'm hoping I can retire. Yes, I would like to do that. Getting to do research in the clinical setting when you're not an employee in the hospital is extremely difficult. You know, for example, I'm not allowed to touch, or as anybody on my research team, unless they're employed at the clinical site, we're not allowed to touch an infant at all. So we have to have the nurse attach our monitors. We want to change the baby's position and put him in kangaroo care and help the mother get him out. We can't touch the baby at all. We're doing assessments, you know, for the Finnegan. We cannot touch the baby to do any assessment. So now you have to hire the nurses from the hospital, and for each nurse that you hire to do, whoever's going to take care of the baby that day, to do these manipulations, etc., you know, to put on a pulse oximeter for us and plug in this thing, etc., so we can get our heart rate data, etc. I have to now pay them their salary, and they have to have a separate consent form, and they all have to be certified by CREC, and they have to be research credentialed according to the national IRB regulations. Those all take about $200, and then whatever hospital they're in, once they start getting involved in research, they have to take 5 courses, some like, you know, university hospital safety procedures, university hospital security procedures, university hospitals research compliance procedures, university hospitals fire and hazard programs, and then university hospitals environmental considerations, you know, like having how many people in the room, how crowded is the room, all this stuff. And that takes some hours, so it adds at least another $2,000 per person. And when you don't know how many people, how many nurses are actually going to do it, you don't want to limit it to just 2 because you want to be able to get as many babies as you can in the shortest time. You're adding easily $100,000 to a project, and it's very, very expensive, and nothing but grief, just nothing but grief to get a clinical study up and going. You have to also have a PI in the hospital, and their liaison bill to be the PI is now up to $5,000. And it's because they are the ones who have to submit the IRB. They will only write to the person who's the PI in the hospital. So everything has to go through that person, come to me to have this change made. For example, in the consent forms now, They don't want you to use the word newborn or infant at all. They want everybody to be called baby. Make it user friendly. Babies, your baby, this baby, and babies will do this, and we're excited for them. So it's a lot of work. We, for the study that I got funded last June 29, 2020, we still are not through the IRB because we had to go through the universities, all of their research new courses, because we are changing diapers and that's touching hazardous human waste. So everybody has to be certified in human waste management, human disposal. I mean, can you believe that? Yes, but that's what you have to do. And then you have to do all these. We had 6 other courses that we had to take just because we were handling a diaper and checking diaper rash and looking for diaper rash because I can't touch the baby at all. And then we had to do the same thing for university hospitals. And we just got notice last week that they have now adopted, as of May 1st, a new system for tracking the patients that you're going to recruit called VELOS, VELOS. And if we want to do our study at university hospitals, everybody who's key personnel on the grant has to do the 5 hours of training for VELOS. I mean, it adds up lots of time. So as soon as we finish the VELOS training, which I hope everybody can get done this week, I hope by May 15th we start with our first baby for the study that was funded last year. And then I'll work on getting the subjects for the study that got funded last week. But 2 studies at a time is quite enough.
That is a lot.
Hello, welcome people. I see we got several people coming on.
We got 10 people. And we'll start in about 3 or 4 minutes.
Okay. So no, I think it's time for me to step back and let my postdoc, Dr. Leisha Clotis, take over on some of these studies. In fact, I just sent out an email to her this morning saying, I think we need a 2 to 3 hour meeting so I can tell you about the studies that I think you should be engaging in for the next 5 years. And I really am going to encourage her to do 2 studies looking at the cytokines for inflammation and seizure activity in babies who have an SUPC. I think we need to follow up on that for sure. And doing some other studies on neurodevelopment of premature babies in kangaroo care. Opioid babies, they really are responding so well to kangaroo care.
Yeah, these talks, we wanted to do it for parents because there is a lot of information for nurses and all that, but we wanted to invite more parents to listen. So we're going to keep it, lay terms, and when you answer, I know there are a lot of clinicians here, and they range from not, parents not knowing very much to very, very proficient people in kangaroo care and leaders in the field as well. So hopefully we get a lot of questions. We will go until 11:30 your time. And so at about 11:25, we need to, stop and see where we are and then just finish the program.
Okay.
So let's see, let's give a couple of more minutes for them to join. Got 3 more. So I would like to ask everyone if you can rename yourselves and say where you are from, either the city or the country if you're not in the US, and if you're a parent or a clinician. Would love to see that. Does everybody know how to rename yourselves?
Deb, can we start with you?
I live in Tallahassee in Florida and work over in Jacksonville. So that's about a 2.5 hour commute from me. I retired from the hospital here in Tallahassee, and I have been following Dr. Ludington since the beginning of my career. So that was in the 80s. And I just am so excited every time I can get to hear her, because I have seen the difference that this makes for these babies. And I am a bedside clinician. I have worked in management, and there's just nothing like being a staff nurse to be able to have that direct one-on-one and that impact for educating and encouraging others and showing them what the difference this makes to do with a baby. So I'm happy for your retirement coming up, but we will sorely miss you. So I know you will put everything in place as you've always done. So best wishes, but no, we will miss you much.
Thank you, but it's not set yet. It's still a dream. I had to get the
I have a lot to see. Yes. Okay, I'm going to mute everyone right now. We're going to start. I'm going to allow you to unmute yourself, but I think what we're going to do, except Susie, I need you to unmute. Did you get it? Susie, there you go. So if you can start sending questions while I'll introduce our amazing speaker today. We are so excited to have Susan Ludington, the leader of Kangaroo Care research and knowledge in the US and definitely in the world. This program is presented by the Kangaroo Care Day. We are a team of people, professionals, parents that want to improve kangaroo care globally. This program is sponsored by the Foundation for Premature Infants and by the Zaki, which is the company that I own, and the products, the Zakis, that I made on behalf of my son, Zach, and in collaboration with NICU Parent Network. And we have Kara here in our leader in the call, the Global Alliance for Newborn Care, and EFCNI from Europe, and Love for Lily. So I want to just let Susie to introduce yourself, tell us a little bit more about you, and take a couple of minutes to tell us who you are, how you started, and just take it away. I'm going to get everyone, if you can, start asking questions in the chat. What we're going to do is Susie will read the questions and she will answer them. So I don't have to come in and out, and she can just answer all the questions.
Yamiel, will we have a chance to hear from the other attendees as to where they are?
If you can rename, so if you go in the name on the 3 dots on the top right,
yes,
you can say who you are, like the name, which most of them are there, and then yes. Put clinician or parent or whatever you are, and then the state or the country where you are if you're not in the US. We are expecting people from 13 different countries, so we're very excited to welcome. A lot of people are at nighttime or late. So Amanda is from Montreal. Welcome. Great. Yeah, if you can put it in the chat, that would be great as well.
Okay. All righty. Well, while they're doing that, I'll say hello. I'm Susie Ludington. I'm a nurse scientist. I started my career, I started teaching in 1972, teaching nursing, and I was in labor and delivery, and I quickly developed a great interest in having more control to help our mothers do the deliveries the way they wanted. So I became a certified nurse midwife, and then after I got my PhD, I really became quite interested in research, and I have been a researcher since 1975 when I completed my PhD. Oops. Okay, sorry. I'll get rid of that phone call. And let's see, I used to do black and white stimulation called infant stimulation for babies, but now that's all over every newborn toy. You have black and white checkerboards or stripes or, circles, concentric circles. And so I moved into working on what I had learned about in 1986, which was kangaroo care. And Jean Anderson was my mentor, and she had called me over at a meeting I had attended in child development and said, "You got to see this, Susie." And I was fascinated by it. And I said, "Jean, it's not in the United States. We got to bring it to the United States because nobody believes anything unless it's done in the United States." So in 1988, we put together a team of researchers with Jean Anderson and myself and my students from UCLA, and went down to Colombia to start doing some physiologic studies on kangaroo care. Had a wonderful time, came back, and then started researching it in the United States. I was the first researcher in the United States to get a National Institute of Health grant, and I've had 8 of those from the government doing randomized controlled trials to establish the safety and efficacy of kangaroo care. And most recently, my research work has moved into doing kangaroo care for our babies who are withdrawing from opioids from their mothers. Oh, they absolutely love it. And we have several publications out on that. And now we're doing some brain studies to look at ways to reduce seizures in babies and continuing to look at the toxic stress as part of the trauma-informed care initiative, the toxic stress that we can reduce by doing all of our nursing care assessments while the baby's in kangaroo care. And I leave it to my other postdoc, Ashley Weaver, to find out how we're going to get all of our mothers to really be there constantly, because even when you use the family integrated model of care, as we know from Linda Frank, we can get mothers probably to stay a maximum about 8 hours a day. And I think it's time for a big initiative to pay the mothers $200 to $300 a day to stay in the NICU with their babies and get some other help at home, because the benefits are absolutely phenomenal. I have 128 publications about kangaroo care. Let's see. And I have several awards. Was one of the very first inaugurated into the International Nurse Researcher Hall of Fame. And very recently, March of Dimes and Excellence in Research from, A1, etc. And my most recent accomplishment that I really do want to tell you about, I'm very happy, is that I wrote the brief number 8 for A1 about sudden unexpected postnatal collapse that was published in both June and July of 2020. And coming out this next month are the international guidelines for kangaroo care during COVID-19 that I also wrote. So that will be out and available too. Okay, that's about it.
Great. Well, definitely a lot of accomplishments. I know that, and I have told you many times that your work has helped babies around the world, and it helped mine, because I'm sure that the research and all the work that you did, was given to the nurses and the therapists and all the NICU staff that took care of my son 20 years ago. And he's a college student now, doing really well. He's an industrial engineer student. So because of you and all the work that everyone in this group is doing, we have good outcomes for babies. So I wanted to thank you and everyone else. So there are a couple of questions that we have in the chat. I want you to start with, what is the difference between kangaroo care skin-to-skin contact and kangaroo mother care, because they're all used in the same way, and I know they're different. So if you can you explain the difference?
Um, okay, well, I want to first set everybody straight about the origins of kangaroo care. It started in 1970 at Case Western Reserve University and University Hospitals by Kennel and Klaus, and they called it extended care. Mothers in 1970 were not allowed into the NICU until the day before their babies were being discharged, and they decided that by 21 days of age for their research study, they were going to invite mothers in and let them hold their baby skin to skin, chest to chest, and they called it extended touch, extended touch. And they were measuring maternal behaviors, attachment behaviors, and they were so thrilled with what they saw so swiftly, because you know, you get this baby on your chest, as your mummies will say to you, oh, it's awesome. I really feel like his mother now. Yes, I need to be here. I need to be doing this for him. And the feeling is immediate. It's a rush of oxytocin that is released when that baby gets on the mother's chest. And that oxytocin goes straight to her brain, to 14 wonderful centers of her brain, as it does to the baby's brain. So it's a very potent hormone, and it really produces maternal attachment, maternal engagement, maternal sense of confidence and competence. It has wonderful effects, as well as what everybody calls bonding. And people were so impressed that parents, mothers especially, were able to show attachment behaviors that Kennel and Klaus became very famous for allowing attachment. And they forgot about the extended touch, the extended care. Then down in Bogota, Doctors Hector Martinez and Edgar Ray were out in a conference up in the hills, and they were taking a morning walk before their day-long seminar, and they saw this woman who was walking with what they thought was this huge mass on her chest. So they went up to her to ask her how she was doing, etc. A peasant woman up in the Andes of Colombia. And lo and behold, she opens her blouse and she says, I am the wet nurse. And when I take care of babies, they all survive. They all do beautifully. And I am the best wet nurse for my village. And she had this little premature tucked right up against her skin and underneath her sweaters. And they took that back down to the Universidad Hospital down in Bogota. And they said, let's do this here. And because they thought the baby, the premature baby, being in the pouch between the mother's breasts was so similar to what happens with our kangaroos, who are born very prematurely and then crawl up between the nipples in the mother's pouch, they called it kangaroo care. But because they knew the baby needed to go to breast, they called it kangaroo mother care. It wasn't, they didn't think about daddies or anybody else doing it, siblings, etc. No, they wanted the mothers to do it for their babies in their intensive care nursery. And one of the local doctors was in touch with Dr. Marsden, who was head of maternal child health in 1983 for the World Health Organization, called him to look at it. And he was so astounded at how well the babies were doing in kangaroo mother care, because the babies had great physiologic stability. And so he brought down lots of people, including Jean Anderson and others and Kirsten Nyquist from Scandinavia and Bjorn Westrup, etc., to come and see this, which they did. And they arranged for Doctors Martinez and Ray to present their findings at a meeting. And then a Dr. Whitelaw went down and saw what was going on. And he said, you know, the data that Doctors Martinez and Ray presented about decreased mortality, they said they had a 75% drop in mortality. Well, instead of using all of the babies in the nursery, they only looked at the mortality of the babies who were given kangaroo care, and that percentage had dropped 75%. And Dr. Whitelaw wrote an article, said the myth of kangaroo care, which was a very sad thing to get out in publication, because then everybody withdrew from Kangaroo Care that was starting to use it in Colombia. They didn't want to be associated with inaccurate data reporting, etc. So it took time for it to come back in Colombia, but Dr. Natalie Charpak, a neonatologist, and her father is also a physician, started investigating it, and she said, no, the kangaroo mother care is very good. Kangaroo mother care or kangaroo care are the same. I call it kangaroo care because it's way beyond mothers. We have grandparents doing it. I documented in the first study with fathers how they can do it. We have siblings doing it, etc. So I said, let's call it kangaroo care. And usually that's the term used for doing skin to skin contact with babies who are in the neonatal intensive care unit or who are premature or who are low birth weight. Skin to skin contact finally started transferring into the full term population when the NICU baby friendly initiative started to gain some interest, and they said maybe the kangaroo care is going to help with the breastfeeding. And Kirsten Nyquist from Uppsala, Sweden, is the one who really spearheaded that database that showed clearly that as soon as the babies get into kangaroo care, and she's talking prematures, but then she started doing studies with some full-term babies. Within an hour of birth, a full-term baby will find the nipple and start suckling. And so initiation changed, and then the mothers seemed committed to it, and duration of breastfeeding changed and increased, and then the exclusives, they also increased. And what they did over 25 years ago at the University of Uppsala Hospital is they started 24/7 kangaroo care. And she's published it. She published it as early as 1990, where the mother and the baby are admitted to the neonatal intensive care unit together. And there's one bed. It's a queen size bed for the mother and her partner to be there, and she is the baby's bed. The incubator is up at the ceiling. And if they really want to get up and go to the bathroom or go out to the family room and get some food or something, the mother pushes the button, brings the incubator down, and puts her baby in the incubator, opens the curtain so the nurse, who has a table in this room of 4 beds, can see and watch the baby while the mother goes out. And usually they like to go home for an hour, or they spend actually 22 hours a day in kangaroo care and have 2 hours off, getting up to the bathroom, food, etc., taking a walk. And the results have been absolutely so phenomenal that Bjorn Westrup down from the Karolinska Institute in Stockholm came to study with Uwe Uwald, who was the head of neonatology, and Kirsten Nyquist, the nurse who was in charge of all this. And several years ago, they got a $20 million grant from Bill and Melinda Gates to start doing exactly what they've been doing in Sweden for over 25 years in 4 different hospitals around the world as part of a randomized controlled trial. And they have, under the World Health Organization, a wonderful publication, tells you exactly everything that they're doing, their criteria for babies immediately. Any premature 24 weeks gestation or more goes right into kangaroo care at birth. And after a year and a half, it was a 3-year study, they had to stop the study early. And the reason they've had to stop the study is because the difference in morbidity or mortality is so dramatically in favor of the babies who were put right into kangaroo care rather than the control group that has been cared for according to each institution's routine care for premature babies. And so it is just unethical to say that you would have babies in a study that you know you are going to deny them the best chance for fewer morbidities and less mortality. So that study has come to an early end, and we're expecting the results any day now. And if you're interested in any of the studies I happen to talk to you about, these are all annotated. There's over 6,000 references now on the Kangaroo Care bibliography that I maintain for the International Network of Kangaroo Mother Care. And it's free to everybody. It's a Word document. I'll send it off to you and tell you what studies you're particularly looking for if I happen to know what interest you have. And I also have over 45 charts. Let's say you're interested in cesarean kangaroo care, or let's say you're interested in what does kangaroo care do for inflammation, infection, immunity, cerebral blood flow, cerebral oxygenation. All of these are on charts where I list the names of all the studies and a one-sentence summary, so you can find them all on the KC BIP.
What is the last year that is updated? Because the last one I have seen is 2018. Do you have a more recent one?
The Kangaroo Care bib?
Yeah.
Well, you're just outdated. It gets updated every Sunday. I just finished adding 6 new articles yesterday.
Okay, so if you can send it to me, I'll make sure that everybody will get it.
And on the first 2 pages, it has the date as was the last updated.
Perfect. Yeah, that would be great.
And
I know that Bill and Melinda Gates have been very generous in donations and grants for Kangaroo Care. One of the grants, we got a small grant to do an application, a mobile application that it's already published, so everybody can use it. And that application is to have parents track Kangaroo Care. So when they share the information with the nurses, then we can do the kangaroo-a-thon and know who kangarooed for how long, if it was mom or dad and all that. So that information I'm also going to send to everyone about the app. So
may I finish answering the question, because I didn't get to the definition of skin-to-skin contact.
Oh yeah, go ahead.
So when Kangaroo Care started being applied to full-term babies, they called it skin-to-skin contact, and that has evolved into skin-to-skin care. And as part of, the integrative family care model, that's what we really are calling it now, integrative care. And this whole history and evolution and telling you the correct origins was published in the Journal of Birth Defects Research, September 2019, in an article by Ludington Ho and Costandi called Evolution of Kangaroo Care. And that whole edition of Birth Defects Research is all devoted to kangaroo care. With cesareans and how to do the transfers again. And Linda Frank has added how kangaroo care fits into the family integrated model of care. Plus we have several articles about why separation from the mother and leaving the baby in an incubator is so toxic to them. Thank you.
Great, thank you. Can you see the questions from
Well, you want me to open chat? I can open chat.
Yeah, if you can open, or I can read it. We have Colette from Ireland, and she says, I'm a NICU nurse, and I have been for the last 21 years. She wants to advocate for kangaroo care, and there are no policies in Ireland. So she wants to know, it says, I am hoping for some advice in the formatting of such policy. What to include for staff in the neonatal intensive care settings?
Oh, well, Colette, thank you for that question. Just this last weekend, I got a call from Utah, and it was from a head nurse of an NICU in Utah who said, we don't do any kangaroo care in our intensive care nursery at all. And I responded, I said, you've got to be kidding me. And she said, no. I said, that's malpractice. And she said, well, Susie, I think malpractice is a bit strong. And I said, well, the only other term you could use is mistreatment. And to me, when you know it has so many benefits, it is not evidence-based practice if you're not doing it. And she said, well, we're not doing it because we don't have a policy. So the Kangaroo Care bib has a whole section of published policies, one from Vanderbilt University, etc. And I know that the United States Institute for Kangaroo Care had at the certification courses a binder of all the policies that you could buy as samples. But we also have an article that's come out by Risa Matzner, Matzner, that was published in 2020 about policies among hospitals for kangaroo care and specifically for sudden unexpected postnatal collapse. So Risa Matzner is also on the KC bib. And for many of these publications, if I know what you're particularly interested in, I try to save the publication, the full, so I can attach the articles and send it off, because that really facilitates people getting a hold of some of the information. But you will see a section on the KC bib called Policies, and you're not alone. And the article by Matzner did a very good job of talking about the essential elements of good policy that every hospital in the United States is supposed to have as part of their risk management.
Can you talk about what would you tell a new, like if you had a couple of minutes with a new parent coming into the NICU, what would you tell them? How would you give them some advice on approaching nurses to do kangaroo care? Not all the nurses are welcoming kangaroo care, especially during COVID. Can you talk about a little bit, during this time, during COVID, parents that are not being able to come to the NICU, what can they do to advocate for themselves and their parent and their babies to do kangaroo care?
Okay, so Yamil, you're asking me what would I say to mothers or what would I say to the nurses?
To the parents, specifically to the parents, to new parents, a new parent that comes to the NICU that doesn't know about kangaroo care, that doesn't know how to approach a nurse or what questions to ask. What would you tell them?
Number one, tell the mother how thrilled you are that she's there. I'm so glad to see you here because your baby knows when you are here. He can sense you. He has your scent from when he was in the womb. And within 10 feet of him, he knows when his mother is here. And your presence alone is calming to him. But you are the very best therapy there is for your baby, because you and only you can offer two well-validated therapies that are going to help your baby survive and going to help your baby stay well and become better sooner. And those two therapies are, number one, to provide breast milk for your baby. It is phenomenal how important this is, and it affects your baby for the whole rest of his life when they're able to get mother's milk for the first 6 months. This is the very best thing you could do, because he's not going to have the allergies, he's not going to have the Crohn's disease, he's not going to develop metabolic syndrome problems as he gets older at the same rate as babies that are fed formula and are not given mother's milk for at least 6 months. And the second best thing you can do is hold your baby close, because you have the most powerful body in the world to your baby, and you are his only reason for living. You are his entire universe. You get him on your chest, and when he's between your breasts, skin to skin, chest to chest, the chest senses this and immediately starts to send very big doses of messages to the brain through a very new set of nerves called the C nerves that were created just to respond to the pleasant, familiar touch of mommy. And when those messages get to the brain, they release oxytocin, which goes to many places and immediately starts to switch your baby's brain from I'm in stress, my mother's gone, where am I? Why am I here? This is terrible. I am so stressed out. I'm so anxious. The babies are, they're restless. Their stress levels are high. Their cortisol is outrageous. It's over 347 and it should be 150. But within 20 minutes on your chest, that stress level has dropped by 80%. And he has oxytocin going to his brainstem that regulates his heart rate, his oxygen rate, regulates his temperature, his immune function, and it stabilizes the babies. And that oxytocin also prevents them from getting infection. It enhances the immune ability of the baby. And it also promotes the baby's brain maturation. Several studies, 5, about how kangaroo care affects brain maturation, brain complexity, brain connections, and enables your baby to sleep. Because when he's with you, he knows he's protected. He's where he belongs. He's with his mother, and he gets the best possible sleep that he will never have in an incubator or when he's separate from you. And it goes to his pain center. So all these things that we have to do to help him will not have long-lasting memory in his brain because kangaroo care decreases pain perception, but also changes the memory of it. Now, we know when you breastfeed, you can stick a baby for a heel stick and get blood. And the pain perception is less, but the memory in the brain is still the same. And over time, being in the intensive care unit, the babies become very sensitive to pain. We call that hyperalgesia. But when they're in kangaroo care, they don't respond to the pain so much. They may not even feel the pain, and it leaves no memory. There are phenomenal things that only you can do for your baby. And you control his temperature so that all of his energy can go to recovery, not trying to stay warm and not trying to overcome the stress and demonstrate to everybody, I'm not happy, I'm not content, I'm not calm here. You are the best thing you can do for your baby in intensive care. And that's why we want you here as much as you can possibly be here.
What about for fathers?
I am very strong about having fathers be involved too, because particularly with the full-term baby, I advocate 24/7 kangaroo care for every day that they're in the postpartum unit. And mommy needs to sleep. She's exhausted too, and I don't want her to go without sleep. So that's when daddy needs to take over. And we know that daddies will also keep the baby warm, but Ludington Ho's study of 1984 showed that, where they can get the baby too hot. So we let the daddy know that when the baby's on your chest, he will calm down. His stress level also drops. We have data on that now from Erlandson. And you will find that he is very contented and goes deeply to sleep. That's true. But if you start to feel too hot, then your baby's probably too hot too. And so it may be time for him to go back to his mother, because when the baby's on the mother's chest, her hypothalamus regulates the temperature of her chest so that every baby stays in the neutral thermal zone. And if she's got, I remember one time we had 5 babies born up here in Cleveland. And so they called me out to, what are we going to do with kangaroo care for these 5 babies in the intensive care unit? And I said, well, we're going to put them on the chest. So I'm going to put this down so you can all see. One here, one here, one here, one here, and one here. We had 1, 2, 3, 4, 5. And you know what? I was there with all of my sensors. And by gosh, every baby stayed absolutely within normal thermal zone. And I was so thrilled with that, but the mother would not let me write a case report because she said, there's really no way I could remain anonymous because everybody knows when somebody's had 5 babies in the United States. So she wouldn't let me report it, but I have it in my unpublished reports and I know what it shows. And I was fascinated because the hypothalamic set point, I always thought there was one, and that we put a baby on the chest and then mommy's breasts would both work, simultaneously to keep that baby warm. If he gets too warm, the baby will go up to 37.4, and then the mother's breast temperature will drop 1 full degree within 20 seconds to keep that baby from going into 37.5 temperature, because our premature babies, or any baby at 37.5 or more, are more likely to have apneic spells. But at one point, with a research team, Tina Lewis, and in fact, we published a study, Tina Lewis as first author, we did it with twins called Shared Kangaroo Care. And the same thing, each baby, one baby, they were already weaning and they thought his temperature was pretty good. So when he came onto Kangaroo Care, his temperature was below 35 and I was really concerned. And that breast just started zooming up. We had a continuous monitor to get that baby up into normal neutral thermal zone. The other baby, they had not started weaning in the incubator from temperature control, and he came on very, very warm. And the breast temperature, which we published in 2000 under Ludington Ho, comparing incubator control and maternal chest control of baby's temperature, showed a very consistent pattern that over the first 5 to 10 minutes, the breast will start to increase, and then they hit a plateau, and it's like they're taking their sensors and seeing, do they need to increase the temperature more for their baby, stay the same, or decrease it? Because for babies that still need to be warm, they will take them up to 37.4, and then the breast temperature will drop. And we found in this study that the right breast can behave very differently from the left breast. And in fact, in one report we had, which we called a baby who did not respond to Kangaroo Care as expected, we had twins on, and one twin was not doing well in Kangaroo Care. He was on the mother's left breast, and his oxygen saturation was dropping, and this is very rare. Usually SaO2 will go up 0.6% during the course of Kangaroo Care. Cerebral oxygenation improves even more. But anyway, this baby wasn't doing well, so I told the nurse, I think this baby is going to have to go back to the incubator and can't stay in our study. And because he started out at 97%, he's now down to 92%. And the longer he's staying here, he keeps dropping. And I said, and so at 88%, he will be no longer eligible. And she said, oh, well, 88% is out of date. We use the guidelines that were set for neonatal resuscitation program, and it says that 85% is adequate. And I said, well, that may be clinically true, but my research study had it at 88. And if I keep a baby after his SaO2 has gone below that, I would be breaching my contract with the IRB and violating my whole protocol. So this baby, if he hits 88, will be back in the incubator. Sure enough, he goes back into the incubator at 88. The nurse is not happy with me, but I have no choice. And what we noticed is that the temperature on this breast, on our graphs and on a readout, we started going crazy, going up and down and up and down. And then the baby on this twin that was on the right puts a hand over here, and immediately you see the breast temperature starting to very slowly rise, none of this up and down and up and down, and it got to a good temperature to keep the hand nice and warm. And then the baby withdrew his hand, and all of a sudden, it's all over the place again. And so we published this in Tina Lewis and Ludington Ho on shared temperature regulation during shared kangaroo care. So these breasts are phenomenal. Daddy's breasts just heat them up too much. But the other advantage of having daddies do kangaroo care is it really enhances their bonding and their interaction with the baby and their sense of responsibility to take care of this baby. And that's what we want. We want our daddies to be supporting our mothers and our babies and bonding to them and recognizing that they have a very influential role on the baby's development. So I encourage that, and as I do with siblings.
In one of the conferences of Kangaroo Care, I think it was in 2010 from the in Canada. Remember, there was a study that there was a family that had a preemie, and the dad had to do the kangaroo care, and it had like he stopped abusing the mom, wasn't it? That it had so profound, uh, change on him that he viewed his wife in a different light. And that, to me, that if that doesn't tell you that it changes people, then nothing does.
Together for this child, and babies need both parents, I think. Yes.
Yeah, it's a sense of, we want many of it, one of the things that I felt when Zachary was born, and we talked with these, about these with my husband, is that, when a baby is born healthy, he has everybody hold him, everybody has, it's an instant family, that they're connected, the three of them. In our case, we were three. And but when Zachary was a preemie, that it was, you have to make an effort to be a family. In the NICU is very difficult. So we had Larry kangarooing. He would come after work. He was not able, obviously, for 5 months that Zach was in the NICU. But we made it, a point to become a family, because usually it's moms and babies, and everybody asks about mom and baby. But we do need to take care of the dads, because the dads are, part of the family. So sometimes it's like, let's include everyone, include the baby, include the mom, include the father, and then the extended family as well. Now we have another question. There is can you talk about the kangaroo care position? Because we see in different photos, and if you Google and if you look at different videos, babies are placed in different ways. They are sideways, they are diagonal, they are, they are with the legs extended or flexed, or can you talk a little bit about the position of the baby?
Yes, and I'm delighted that somebody has asked about that, because it really is a very standard position that is one that is safe. And the baby should be like a frog. He should be flexed at the elbow, and he should be somewhat adducted and flexed at the hip and flexed at the knee and flexed at the foot. And the position is very important, because the C. afferent nerve receptors are especially dense between, I need to bring this down so you can see, between the right nipple and the left nipple. This interface, chest to chest, not out on the sides. You don't have such a density that the messages are going to be so potent to have the benefits of kangaroo care. So we have been putting the babies in an upright position, because we really want them to have the benefit of, gravity helping with their breathing. And of course, because sudden unexpected postnatal collapse is occurring, and now everybody in the United States has to report that as of January 1st, 2019, to the Joint Commission. It's called Perinatal Care Mandate 06. You have to report that, you have to be sure that the baby is positioned in such a way that he always is able to maintain his airway. So the head has to be one side or the other. And this is one of the studies that I was thinking of embarking on, which would change my retirement plans. I really want to look at the cerebral oxygenation, cerebral blood flow, and cerebral blood pressures when we change the head to one side or the other. We have not had any troubles with this, nor have they in Sweden. And even in the babies who up to 34 weeks in the first, week of life are very susceptible to intraventricular hemorrhage. When you look at Goldsmith's article of 1983, that was in Critical Care Medicine, he clearly documented reported that there was more vacillation in blood pressure and blood flow to the brain when the babies who were under 34 weeks had their head turned to one way or the other. But this has not been documented in thousands of babies that have been done in, over in Sweden, and the babies that we have done as well. But I thought nobody's going to be at peace until we get some actual data on it. So that's one of the things I kind of want to do, but I have to think about whether I have really time left in my life to do all of that.
You have to. You have to.
Well, I know, but after 50 years in the business, I'm kind of feeling a little bit old, and my sister wants a playmate. Anyway, the other important thing is that the babies have their face visible at all times. I know mothers love to cover babies. Every time I go out and they have a baby in a stroller, they've got them completely covered. And I go to everyone and I say, oh, please don't do that. You need to be able to see your baby's face and look for color changes if you should start to have some problems breathing, and you won't see it. That's how we get babies with that serious HIE and other problems. So I want the head turned to one way or the other, the nose and mouth uncovered. I don't put babies up on the shoulder because we have documentation of some babies that they extend their head over the shoulder and they occlude their airway. You don't want them in their heads to be bent back either, because that can occlude the airway. And if you let the baby come over to the nipple, you notice that you got to watch him closely and support his body so his head doesn't slide underneath the nipple, which is called overlay, and then that occludes their breathing as well. And I generally will let a baby sleep on the mother's breast as long as the face is turned towards her midline, so that she can watch her baby's face and make sure the baby can continue to breathe. Now, there are two reports in the literature of different positions, one called a koala and one called an oblique. And I remember when Children's Hospital of Philadelphia called me on the phone because my doctoral student who was there wanted to do kangaroo care for the babies that were coming to the cardiac unit right after open heart surgery. And since then, Tandy Harrison and I have published a few articles about kangaroo care, how it really promotes recovery after open heart surgery. But this day that they called, she said, Susie, we really want to copy Gazzolo's work that came from Italy, where they did kangaroo care immediately after open heart surgery. But because we only have this plastic sheath across the baby's chest so that it can expand due to the swelling that occurs after surgery, we're a little afraid to put them in the classic kangaroo care position, head up, vertical, like a frog between the breasts. So what do you suggest we do? And we had a wonderful meeting by phone, and we had pictures that they were using on their cell phone before we had Zoom. And we found that we could move the baby. I'm going to go down so you can see my breast. We could move the baby. So we lifted up the breast so that the baby was at an oblique lie, and this breast was on the chest. And then we made sure that this breast was also on the baby's bottom area, lower abdomen and legs. And so the mother held the baby like this, and it enabled the chest to expand. And they have since published some work that they have done. They have a whole policy now for at Children's Hospital of Philadelphia, whole policy for kangaroo care in the post CHD, congenital heart disease patients and defect patients when they come to surgery. And Tandy Harrison, who is down at Ohio State University in Columbus, and I have completed a report where we did kangaroo care up at university hospitals here for a baby that was waiting to be stable enough to go to surgery. And as soon as I hear stable enough, well, then you've got to get them in kangaroo care. And so we got permission to do a study when she came up here to work with me for a few weeks. And we got to this mother, and she was delighted to have the baby in kangaroo care. And we measured everything we could possibly measure. And of course, when the baby was in the open air crib, it's a full-term baby with a defect, very unstable, and you could see why they needed the baby to get a little bit older and try to stable out all the vital signs. In Kangaroo Care, everything went immediately stable. And then when she put the baby back at the end of the day for the overnight period, because she wasn't allowed to stay in the room, the baby went right back to where he had been. But the second day she comes back, and this is when we asked the nurses, please, will you let the mother stay with the baby? And by the third day, they all decided this baby was stable enough to go and have his surgery. And so we have the only report coming out about Kangaroo Care to prepare babies for open heart surgery and bring them to a state of stability so they can have it earlier than they would otherwise. But that is an oblique position. I have to warn everybody that as soon as you move this baby as soon as you move the baby even 1/4 of an inch away from the mother's skin, the baby can get cold. He has to have the contact for the breast temperatures to regulate and maintain his temperature so he doesn't have any hypovolemia. And if you have a problem with babies coming to the NICU that are cold, it tells me for sure you haven't got them in Kangaroo Care. And now with the study that's going to come out, the World Health Study from all of the very early Kangaroo Care, and there are many, many articles in the Kangaroo Care bib about micro prematures, very, very small babies, 24 weekers on up that have been in Kangaroo Care and how beneficial it is. And that's how Bjorn Westrup and Niels Bergman got, the database to get 20 million from Bill and Melinda Gates to try it as a randomized controlled trial of 4 hospitals around the world. So there's benefit to doing it with earlier. The babies who have the greatest benefit from Kangaroo Care that you can measure in terms of morbidity and mortality and discharge and days till he's, nipple fed, in number of infections, etc., are the smaller and sicker babies. And that's why they picked every baby from 24 weeks gestation on.
There are some people that talk about Kangaroo Care with the saran wrap of the baby when they're very, very tiny. What do you suggest about that?
There's research that has compared the saran wrap to Kangaroo Care, or taken a pretest with saran wrap and then have the baby go into Kangaroo Care for an hour, 2 or 3 or 4, or however long. But I imagine what you're going to find is much better thermal control, because that's what Mother Nature has programmed the mother's breast to do. Control the temperature of her baby so she does not have to spend very valuable metabolites and energy trying to stay warm. Mommy provides that.
But should they use the saran wrap and put the babies on skin to skin with the saran wrap?
Imagine that the saran wrap is going to cut the effects of the oxytocin and the C afferent nerves, because I've seen people use a milk pad in Kangaroo Care, and as soon as it's on that interface between the nipple to the nipple, it stops the C afferent nerves, and that's already been published in the literature. I've seen them even from Children's Hospital of Philadelphia, they had pictures in a video and the mother was wearing a bra. Absolutely not. You're not going to get any of the benefits if you have any kind of interface between the skin to skin contact. This is a point where the evidence isn't there to make a statement of what the effects will be, but I certainly hope somebody would think of doing a research study to that effect. And if somebody wants to do that and they need some help, I love doing that. That's my love of my life. So I'm more than willing to help people in other places get their studies together.
Great. Now, the saran wrap is around the baby before they put, they cover the baby around and then they put it on skin to skin. It's not that they put it like the baby, the mom, the baby, and then the saran wrap, right?
I believe so. Usually this is an intervention. They start right in the delivery room to try to maintain the temperature, because they have more faith in saran wrap than they do in mothers.
So what about humidity? Because most
Ludington Ho published a study about humidity, and it was with Dr. albuterol. We measured that and we reported the humidity because we were getting from the nurses, oh no, the baby needs to be in the incubator to have proper humidity. Actually, and the report shows that the humidity was well controlled and in the ideal range for the babies that we studied in that randomized control trial.
Okay. Now,
Albuterol and Ludington Ho. She was one of my PhD students.
okay.
On the Casey bib.
There is another question. It says, how much of an increase in oxygen would you consider stopping KC? I had a twin baby weighing 1,100 grams, and he went from 26 to 38% during KC, while in KC with the other twin.
38% SaO2? He only went up to 38.
Don, can you unmute yourself?
Is that Don Miller?
Yes.
Because I know Don Miller. Hi, Don.
Hi, how are you?
Tell me about this.
Oh, well, so the twin I had, the little boy and the little girl on the chest, and the little boy just kept having to go up and up and up on the oxygen. Little girl was fine. And so he went from 26 to 38% during the kangaroo care. And I kept telling the mom, I said, everything's okay, because the benefits of him being there outweighs him just needing that increased oxygen. But other than that, he was sleeping, he was fine. But they were born at 25 weeks at 500 grams. So now they're 32 weeks, but still extremely low birth weight infants. But the mother was worried, you know, that the baby had required so much increase in oxygen. So is there a point where you say, okay, that's too much of an increase in oxygen and we should stop kangaroo care?
I'm going to have to refer to the clinician's expertise in this.
Oh, okay.
I mean, you have there's no study that can answer that question at this time. And in the KC bib, I don't see it. And I stay pretty much up to date with everything I can get. I don't know of any evidence. So we're back to clinical expertise and what that can help us learn. If you have to, I'm surprised that you have to keep raising the oxygen level.
You know what was the funny thing too, is as soon as I put the sister back to bed, and so he was on the chest on the mom by himself, his oxygen requirements started to go down. So the mom was like, I think he just doesn't like his sister next to him.
Clearly, you know, Don, you taught us a very important thing, and I wrote it many years ago, that the real expert in kangaroo care is the baby. What he can tolerate and how he tolerates, which is why when we had that baby who had a dropping SaO2, but he was not on oxygen, and if he had been, then, you know, he would have had to have increases, is that the baby, it will tell you what his system can and cannot tolerate. My guess is that, were you monitoring the temperature of the baby at the same time?
No.
Because I know that the breasts start to heat up for 10 minutes, and that probably is a thermal load that baby could not tolerate at that time. And that probably drove, and you would see the heart rate also change, and that would then drive the need for higher oxygenation. But usually, you know, remember, kangaroo care does not raise SaO2 dramatically, 0.6%. That's not even a 1% change across all the babies that have ever had it. So to know that the SaO2 was, you know, dropping and the baby needed other oxygen to support it says to me that the kangaroo care was too stressful on, and you did the right thing. We want to do whatever we have to do, and it's a wonderful thing that we have our nurses and our abilities in our intensive care units to monitor and help each baby until they can tolerate whatever it is that they're encountering in their environment.
Yeah.
I don't know any published guidelines. I don't know anything on it.
This mom rarely kangaroos both twins at the same time. So I was encouraging her to do both of them, because they're now 32 weeks now, gestational age adjustment. So I said, you know, let's do both of them, because she would just do one and then the other one the next day. And I said, let's do both of them together. So this was only her second time doing both of them together.
So, and the babies have been okay on their temperatures?
Yes.
Yeah. And
Yeah.
how
They're both
mommy
in the incubator, wrapped up with clothes on. Yeah, so they're really good with temperature. In fact, they're a little too warm sometimes.
And is mommy happy with her experience? Is she still?
Oh, yes. Oh, yeah. Oh, yeah.
That's the most important thing, because that's going to keep her back and help the babies avoid the toxic stress of separation.
Oh, yeah. And she had a mirror. She kept looking at the baby, making sure he was fine. And
Good.
yeah. Yeah.
Well, you may be interested in the Lewis and Ludington Hull article about shared kangaroo care. And there are several other articles out. That just happens to be the one that I remember we did and published.
Okay. Yeah. Thank you.
Thank you. Thank you for being in touch with me in the past.
Oh, you're welcome.
Now it's already 11:30. And we have a couple of more questions. I know people need to leave. We did say that we would stop at 10:30, but do you think you can stay a little bit longer, Susan? Because
I have faculty meeting at 1.
okay, so we can stay a little bit more until and answer a couple of questions that are here. So I want to thank everyone that joined. We will stay if you want or can stay. You will get the recording of these if you just because.
Have they been given my email so they can request the KC bib or whatever?
Yeah. What we can do to make it easier is that I'm going to publish it in the Kangaroo Care website, if that's okay. Yeah. And then send email to everyone when I do that. And then we'll keep updating. Whenever you have an update, you just give it to me and we update the website.
I'm not going to send you an update every week. It's all I can do to get it up.
Or you can tell me where to get it.
Yes.
In the
And my email is very simple. It's susan.ludington at CASE for Case Western Reserve University at case.edu, an educational university.
Perfect. So let me give it to everyone. So it's Susan
Ludington at case.edu.
Perfect. Great. So there is another question that we got, and is preemie infants that are swaddled in the NICU at 1 or 2 months of age. How beneficial is it? How can we encourage staff to continue KC even if the baby is swaddled? Swaddling to me is a very very controversial issue. I have a very strong opinion of swaddling, which is like a straight jacket. I think it keeps the baby quiet, but it doesn't teach them how to self-regulate. It doesn't give them good position. It doesn't, so it's a good place and a good time to use it, but it's not 16 hours a day. So can you talk about those babies that are no longer in the incubator and they're in open crib, and then that's where most of the kangaroo care duration drops? Can you talk about that?
Yes, when one looks at all the phenomenal long-term outcomes, because over 4,000 NICU prematures have been followed for now 25 years, and we have, by several different authors, intelligence quotients are much better, their social skills are much better, they've gotten much higher paying jobs, they've completed schools that the control group didn't do, really much better psychosocial cognitive development all around for the babies that get kangaroo care. You have to realize that those results are coming from mostly Colombia and third world countries, where they have the mothers carry the babies up to 2 years of life, premature baby, and definitely up through the first year of life. Somewhat like what we learned from Peace Corps when they had, the babies in a wrap that they would let them, a sling that they would hold them in. But these babies are held in kangaroo care in an upright position and have big sarongs around them just to keep them up against the mother's chest. So I've often been asked, how long should babies really be in kangaroo care? And I would be thrilled if mothers would consider carrying their babies 24/7 as much as possible. And they even sleep with their babies, always with about 3 to 4 pillows, and the mother's upright, and making sure that the baby is in a safe position, which we published in 2014, and it's available. And the American College of Obstetricians and Gynecologists has fully endorsed and include my safe positioning checklist and pictures in their recommendations to all obstetricians taking care of newborns, etc. So they can even sleep with them, and they do that I also do that in Sweden, because they are providing 24/7 care. So babies are slept by the mothers, and they keep them there even if the babies are 2 to 3 months old before they go home from the NICU. I would love 3 months of kangaroo care.
So we actually, we say that from 1 pound to 15 pounds, and 15 pounds is usually like a 3 month. And then, or when the baby just says, I don't want to do it. When they start squirming and they just say, I'm getting too cold, that's their first signs of independence, is how I call it. So is that?
Well, you raised something that it gives me a red flag in my mind, because I remember in Natalie's early studies, she said that she didn't think kangaroo care should go beyond 38 weeks post-conceptional age, because she saw that babies were getting restless in kangaroo care, and that she interpreted to mean that they didn't want to be there. And you just were mentioning until a baby starts to give you cues. And I brought this up to Natalie, I think back in 1986, when we all met in Italy to talk about kangaroo care. And she has since resigned from that position, because I've shown her so many babies in our studies that are older than 38 weeks that are loving kangaroo care. So to say to stop it routinely I thought was more harmful than good.
I think saying to stop it at a certain age, like saying you have to feed them at a certain time. The baby would tell you when they get too hot.
Exactly. The baby is the best expert. He'll tell you. You'll see the signs. And when the mothers have been doing a lot of kangaroo care, they're very astute, and they're very sensitive to baby's cues, and really do a good job of interpreting the meaning.
I think another misconception, or another frequently asked question, is who can kangaroo care? Because they think that it's only mom and dad, and it's really anybody with a healthy chest, right?
Grandparent and siblings too. Oh, what it does for siblings. We don't have anything documenting oxytocin in the child who's kangarooing his newborn brother or sister or whatever. But I imagine, because we do know C afferent nerves are there throughout life, except that once you hit 60, they're no longer so dense on the chest at all. They're mostly down on the forearm, which is why elderly people love to be touched on their forearm. It sends off the oxytocin to their brain. But at this point, you can do it with anybody as long as it is safe. And I think there are probably going to be benefits, but there are no randomized controlled trials of grandparent kangarooing. There's nothing with siblings yet either. But I can tell you that, and I put it as the introduction to my book, that when I had been called in on a case that was back in Boston area of a baby who was born quite early, and they had told the parents the baby was going to die, and did she want to say goodbye to her baby, and that she would be allowed to sit beside the baby's bed incubator, and they would give her baby to hold. And they drew the curtains around her. And when they came back, because they were watching the baby at the desk, on telemetry, and they saw that, well, his heart rate was starting to stabilize, and his breathing was becoming far more regular. The apnea attacks had dropped by 65%, which is what we found in a 1984 study, published it at the same time. So that apnea drops by 75% during kangaroo care because of the stabilization of oxytocin on the brainstem. So the nurses came to see what was causing such a change in the baby, who they thought would be dead within an hour or two. And the mother had totally taken all the baby's clothes off and put the baby skin to skin on her chest. And if she left, they found out if they took the baby away from the mother and put it back in the incubator, he started to deteriorate immediately. But then very quickly gave her back to the mother and said, "Oh, I'm sorry, you're stuck here for a while." And she immediately recruited her husband and grandmother to start taking shifts. And they kept that baby alive for the next 2 to 3 months. And he went home. And he's in
When I went to a kangaroo care, the Kangaroo Care Center in Colombia, this was long ago, like maybe 10 years ago. I saw they were discharging twins at 1,200 grams in Kangaroo Care. And I was like, no way. They put one in the mom, one in the dad. They gave them the oxygen tanks and off they went. And I was like, and so what they do is they just, if the mom needs to move it, give it to the whoever has a healthy chest in their community, and they kept those babies, alive and thriving. And it was amazing. Like I would never imagine seeing those such tiny, tiny babies going home.
That's Natalie Charpak's work, and she has started in Central and Latin America and South America over 10 centers of excellence for kangaroo care in neonatal.
India as well. I think when I went to India to visit the Kangaroo Care Center there, they also, Charpak had been there.
Yeah. And her kangaroo.
They went to Colombia. They go to Colombia to train. I believe there is a 3 or 4 week.
Yes, it's a 3-week program for physicians. Costs $25,000 per physician. And I know it's for clinicians, because I wanted to take the class. I didn't know it was 25,000, or else I wouldn't have asked. Well, you have to be a physician, because she takes you up to the units, and then you can write orders on the babies, determine who's ready for it. Another thing that Natalie's had to back off of is she said that kangaroo care was only for babies who were off of oxygen support, and that's quite outdated now. I mean, we used to be much younger.
Well, I held Zachary. He was born at 28 weeks, and I held Zachary the next day. And my experience, I didn't remember kangaroo care, even though it was, I was a little girl when they, it clicked later, because I am Colombian, and it was on the news when they were talking about, how kangaroo care was invented in Colombia, and it was for preemies and all that. And when Zachary was on the bed, and the nurse asked me, "Would you like to hold him?" I said no, but I said, "Why?" I said, "I don't want to hurt him more." And the nurse told me, and this is probably the answer that has me working on these today. She said, "You will hurt him more if you don't hold him." And that gave me the message that I was important, the message that I had to be there, the message that I was his mom. And then I held him every day. And then when the flood happened, when I came to the bedside, he had been without incubator for several hours, and the nurse was bagging him. And I asked, "How is he?" And she said, "He's getting cold, obviously." He's 2.5 pounds and without incubator, and he had a lot of towels on top of him. And so I said, "Let me hold him," because I knew that I could keep him warm, and I've been keeping him warm for 3 weeks already. And she says, we don't want to move them. So I ran to the attendant doctor, and I asked him, I said, "Can I hold him? Let me hold him." And he said, "Of course, that's what you should do." So I put Zachary on my chest, and you know how you say that the temperature of the mom changes according to the needs of the baby? Yes. Well, I went into a fever, because he was so cold. And they put him on me, and then they put a lot of towels, because thinking that he's going to be cold. I just went like a, and then he got cold and we had to remove the blankets after, you know, yeah, I think it was like 30 minutes or so. And my husband was taking, you know, took a crash course in bagging. But yeah, I see all the benefits that you see, that you have seen in research. I experienced them. I held Zachary for a long time. One of the hospitals that, you know, where he was born, he, you know, he was very progressive, even to this time was progressive. I held Zachary 5 to 7 hours every day. And the other one, I asked, can I hold him? And they said, you need a doctor's order. And I said, okay, can you please go get it? And they would come back with a 15-minute Kangaroo Care order. And I just needed him to be on the chest. So I would say, okay, I'll take 15 minutes. And then after the 15 minutes, the nurse would come, okay, we need to put him back. I'm like, no, let's, you know, what do you need to do? Take the temperature on me. Because I had already 3 weeks of training on how to do Kangaroo Care with Zach. So different hospitals have different policies. You know, how do we improve awareness of Kangaroo Care? I mean, we have obviously the Kangaroo Care Awareness Day. We have all kinds of education available. We have your certificate information. What else can we do as professionals, as parents? What else can we do to raise awareness, to not separate these babies, especially now in COVID? I mean, it has been, you know, devastating, because for us as parents, you know, we've done so much work to consider parents as team members, you know, to take care of these babies, something that we can do that nobody else can. But then when COVID came, that went off the window. Many Kangaroo Care, you know, efforts went off the window. So what can we do? What is your word of advice to parents, to clinicians during COVID? I know it's not as stringent as last year, but there is still a lot of don't come, you know, or only hold for 1 hour, or you only can come in one time, and if you leave, that's it for the day, or only one person can come. There is a lot of restrictions.
Well, I appreciate the question, and I'm going to start at the end because you're mentioning COVID. And in the COVID article that's coming out, I have a table of all of the policies that have existed up until February 5th, 2021, which is when I got the last galleys. And there is from San Joaquin Hospital in California. They wanted to make sure that everybody knew during COVID that they could be kangarooing. So as soon as a mother comes into the NICU and right after they have washed their hands, there it is, please take one. And it's a sheet and says, you are important to your baby. We want you here as much as possible. We want you doing skin to skin. And I think that in the units that I've seen, and I go around because I'm looking at places now where they're worried about sudden unexpected postnatal collapse, etc., I still don't see posters up. Posters that show mummies that are doing kangaroo care so that the mothers can see it and start to question about it. I don't see the book at, that mothers are able to add a picture of their baby to this big scrapbook and write a comment about what kangaroo care meant to them. And these kinds of elements of visual reinforcement of what the practice is will work when we're all back to pre-COVID times, when we can have lots of people around all the time and flipping through a book. But I know that my friend Paula Mayer found that these two approaches, really good posters all over, pictures of the mothers doing kangaroo care, doing breastfeeding, and having them put their pictures of their babies at breast in a book and how many cc's you took this day, is what kept this inner city group of mothers coming back day after day after day to breastfeed their premature babies. And she has a phenomenal exclusive breastfeeding rate for premature babies at the Rush Presbyterian Hospital in Chicago. It's up beyond 98%. So those two methods are things that I think people need to start on. And I saw once down in North Carolina this beautiful poster. It had a total of 9 pictures, and it had a baby, different babies in each one, all races, etc. And underneath each picture, it gave one of the benefits of breastfeeding. And I thought that's the same sort of thing we really need for kangaroo care. Different pictures and just one benefit: brain maturation, much less pain, no stress, relaxed, calm, better regulation, self-regulation of his behavioral states, etc. I mean, I can tell you all of the 9 whatever benefits that we really need to let the mothers know kangaroo care does. So I hope somebody at some point will follow up on the publications that Paula Mayer had out on what she felt really helped get kangaroo care sustained. Well, she did it for breastfeeding, breastfeeding a sustained behavior in the neonatal intensive care unit.
Can you talk about birth kangaroo care and your study about exclusive breastfeeding for 2 hours instead of 1?
Well, birth kangaroo care is wonderful for adaptation, physiologic adaptation. Our 2018 article clearly showed that your APGAR, if you really scored the babies by APGAR, the APGAR would be a very bad APGAR, because to get a good APGAR, the baby has to be crying, has to be very active in his movements, and the babies are just not like that in kangaroo care. So we documented exactly what they were like. And yes, they do go to breast, not necessarily at 52 minutes as we've, commonly seen in many babies, but certainly within 2 hours they will go to breast. And then the mothers often say, well, I guess I'm going to breastfeed. I wasn't planning on it, but she found the breast. So, I guess I'm going to breastfeed now, following the baby's lead, because the baby knows what's best for him. So it really just reinforces Bramson's work of California with over 5,000 mothers, where they found that if you put the baby in skin to skin within a minute of birth, which is why it is now the Joint Commission mandate that babies be healthy term newborns, be in kangaroo care within 1 to 3 minutes of birth, that it really promotes the breastfeeding initiation, duration, and exclusivity, which is really the greatest gift a mother can give her baby. I know I put the best you could do for your baby on my kangaroo care book, but I would have to change it if I was allowed to rewrite it, and I'd say the second best you can do, because breastfeeding has implications throughout the whole life. And I know that we now have many studies of the effects of kangaroo care, but that's so dependent upon a very specific duration. And the hospitals in America, particularly with full-term babies, they'll just barely let the mother do it for 2 hours after birth. And really, like I did with my niece down in Virginia Beach, I said 24/7, that's what you're supposed to be doing. And the nurse came into the room. She didn't see me. I was behind the door. And she said, well, I'm your postpartum nurse, and I want you to know there's just 2 things you have to do while you're here. 1, you have to breastfeed your baby, and 2, you got to do skin-to-skin contact. And I was so thrilled. And I use it in any of my talks because I show pictures of that baby, because he definitely looks like the babies that we studied in 2018 and published, and is doing very well. Yes. But the duration really for breastfeeding, we all know it has wonderful benefits, but it has many, many immediate benefits. And so does kangaroo have immediate benefits. But the duration to have the long-term benefits is based on studies where they really give up to 1 year to 2 years of contact. And mothers in America just don't do that.
Now, Amanda had written a question that I forgot, that I missed for some reason, but here it is. So are the benefits from Kangaroo Care coming from the C. afferent nerve stimulation or oxytocin release? My guess is both. How do these two work together exactly? What is the pathway?
What was the first part of that? Was it CNS regulation you said, or oxytocin?
Are the benefits from Kangaroo Care
Yes.
coming from the C. afferent nerve stimulation or
Oh.
oxytocin release?
Oh, well, they are one the same, because the C. afferent nerves go to the brain, and the brain, in response to any stimulation from a C. afferent nerve, which only responds to pleasing touch. And that usually means non-phasic touch, not like massage, not like petting the forehead, stroking the arm, patting the back. No, non-phasic, just here I am, and I'm in this area where the C. afferent nerves are picking me up, and then they just release oxytocin. The C. afferent nerves do not have any other purpose but to release oxytocin in the brain, which is to help everything, that help all brain function. You know this because when your cat purrs, he's releasing oxytocin into his brain, and he's able to do that without the touch. Human beings are not. It's a response to C. afferent nerve stimulation from pleasant, non-phasic touch. Now they're using it. One of the PhD students, after hearing me talk to the PhDs at Case, started applying it to elderly patients, because if you just stroke them on their arm for 6 minutes, you can get lucidity, and they can answer questions in patients who even have bad Alzheimer's and dementia cases. So, and it's a oxytocin sprays and stuff like that.
Wow.
Oh, it's being very widely used, pleasing touch for helping demented and elderly patients and Alzheimer patients, yes.
Yeah, touch is what started me with the Zaki. You know, being able to touch Zachary when I wasn't there, and leave my sense, and when I was not there. That's how my experience started. Let me see. Is there any other questions? We have Susie here. I think we have them all. If I didn't get to your question, please type it again, but I'm trying to go through it all the time, and I think we got them.
Emil, can you, I know a couple of us had expressed interest in the pictures of Sweden with the isolates that she's described. I've heard that before as well, but I've not ever been able to see the pictures. Does she have any of those to share?
I do have pictures in a camera. And I know Niels Bergman, because we were all on that tour together, took lots of pictures and he shared it to me.
Is it in Karolinska?
Pardon?
Is that in Karolinska? In the hospital in Karolinska?
We did not tour Karolinska. We were in Uppsala, and we toured Uppsala.
Okay.
It just took my breath away when I saw incubators up on the ceiling. And I
will look for those pictures. If you have them, please share them with us.
I would have to find them, and that's a big chore because they're not articles. And if you saw my office here, which is why you have a blue background, I probably have 50 cabinets here with articles.
I've been there.
I do remember that I see something over there with some picture folders. I would have to go through it, but I'm very busy trying to get this new grant up and running very fast, because I need to get it up and running within 3 weeks, and that's going to be a lot of work for me. So it's something that would be happening over the summer, because my mother-in-law has decided I have to clean out my office here. It's just I can't stand it anymore. So.
That's funny. Okay, so any other questions?
If you write to Niels Bergman or write to me, I'll send you. He's always available, and he'll share his pictures of it.
Okay, I think that would be great.
And he's far more organized in finding things on his computer than I am.
Yeah, okay, great.
Susan, I got one question. Did you get my book I sent you?
I I think I probably did, and that must be on to you. And that makes me sad. I'm sorry. I don't know where your book is here. I
Uh-oh.
see all over of books everywhere. But yes, I do remember you sending it. So tell me what you're doing with that now.
Mhm.
I just wrote a book about the ABCs of kangaroo care. So what I do is from A to Z, listing the benefits of kangaroo care. And I didn't think I was going to be able to do from A to Z a benefit of kangaroo care. And I actually did find every single alphabet and more on some of them. So all the benefits of kangaroo care into one book.
Now, you know, when you say that, I don't remember receiving that. I know somebody sent me a book that they had written, which was to introduce the family to kangaroo care and how the baby should be positioned and how long it would happen and what they would notice. But it was a family-oriented book. It was not benefits from A to Z. So what did you put down for Z?
Mills, the kangaroo Zach. The
Ah,
Zach Zach.
okay.
and then much needed Z's.
Uh-huh.
Yeah, much needed Z's for the parents and for the baby.
Well, what? No, I don't remember seeing that. I'm sorry.
Yeah, so I sent it to the school, to the Bolton school,
And when did you do that?
probably like 2 weeks ago.
Oh, well, you know, we're not allowed on campus until September 1, and they took us away from our campus on February 26, 2020.
Okay.
I will send you one. I have a copy, and I will send you one to your house.
Oh, I've got to see that. You know, they turned our whole school of nursing, because it's near Cleveland Clinic, into a COVID hospital. And
Oh, wow.
offices
Oh.
we still are not back in our building, but not till September 1. So any mail there is still there.
Okay.
Wow.
No, I'm interested to see that. See, you've already got to start on that poster.
And I did the poster too.
Oh, wow.
Yeah, I have a poster too that says the ABCs of kangaroo care.
Oh, fantastic. Oh, I got to see that and share that with everybody.
Okay.
Oh, you should be taking that and presenting it at the International Network of Kangaroo Mother Care, which we're going to have our meeting in Madrid. Yes, you got to come. November 20.
What is the website? Can you type it in, or what is your website?
Oh, my website?
Where people can buy the book.
Yeah, I can type that in.
Is at the top, at the beginning of the Kangaroo Care bib. When you get that, it says where the next meeting is. And I think, like I know that Dr. Payas at PALLAS is on our steering committee, and she's organizing that. And they put out a call for abstracts, and we love to have poster presentations. If you're expecting the International Network of Kangaroo Mother Care to pay your way, you're absolutely wrong, and they never pay anybody's way. And in fact, we always make donations so that people from like Madagascar, Indonesia, who don't have the money to come to meetings, that we can buy their airfare and, 3 nights in a hotel for them. So you'd have to pay your own way. But I can put you in touch with some nurses from Canada who joined us when we were in Trieste, Italy in 2018. No, I'm sorry, that was in 2016. And they came to present their procedure for moving the baby, a ventilated baby into an out of KC, and what they got out of the experience. And they loved it. Of course, they added a week and went sightseeing too. So I can give you their name, and they published it. You'll also see their publication in the Birth Defects Journal, the September 2019 issue. Debbie Schwartz was her name. So
yeah, she's Dawn. They're also, I believe, in our Facebook group for Kangaroo Care organizers.
Okay.
So yeah, so Dawn mentioned the Zaki Sack. The Zaki Sack is, I wanted to explain what, because not everybody knows, is when I held Zachary, I was able to hold him for a long time, but it was difficult to hold him. He was full of stuff. And then after a little bit, he becomes a little bit and more heavy. He seems more heavy. So I engineered the Zaki sack, and also known as the kangaroo sack. And that's basically to provide safety, access to the baby. I used all my engineering degrees and education and my personal experience to see what is it that we do need when we hold a baby on skin to skin. So that is a product. You can see it in the Zaki.com. I'll put it on the, and then you go to products and see, but there is research there. There is, we're doing a lot of, research also on risk management, because having a baby outside of the bed, it's risky. So with the Zaki sack, we want to decrease that risk of extubation, of, increase the comfort of the parent, increase access to the babies. So, so between the Zaki sack for safety, these educational Q&As with experts, the app, we're doing a lot of work, and I'm so happy that all of you are joining us. So I think if anybody has any questions, speak now, because when is going to be the KC meeting in Spain? Oh yes, that's the book.
There's the book.
Oh,
Yeah.
oh, I'm very excited about getting to see that.
Lots and lots of pictures of moms and dads doing kangaroo care.
It's lovely, lovely, lovely.
Don, if you come to the meeting in Madrid, you should bring several copies with you. I know that selling things is very hard there, because people really don't, most people coming don't have much money, but
Right.
if you have some to give away. I mean, you're going to meet the heads of, health departments for whole countries come to the meeting, and neonatologists, and I would certainly, have a few copies to give to those people, so that you can get invited to them to come to Nigeria and help their efforts with kangaroo care.
Trying to make me an international traveler, huh?
Absolutely, Dawn.
Very, very much looking forward to help, and people who are willing to travel to them.
Yeah. Yeah.
Monica, the next meeting is in Spain. So I want to give a little bit of explanation of what are the meetings that we're talking about. So there is the KC certification course that is given by Susie in Ohio in about May or June, depending on the year, but she hasn't had
First
a
in
year this year. She's going to resume that next year in June. That's the scheduled time. And it's going to be in Ohio. The other meeting is the International Network for Kangaroo Care, which is a meeting. Susie, can you explain what the meeting is? I've gone to every meeting since 2010, but it's basically what she was talking is the decision makers of kangaroo care of every country, third world countries. The Gates Foundation is there, the WHO is there, Susie is there, obviously. I go because I love the meeting. But
it has 2 days of workshop where you will be assigned to a workshop to produce a document. And then we have 2 days of presentations, the latest research, the latest innovations in implementation, clinical issues, etc. And it's really the overarching theme of all of our meetings, which are every 2 years, is how to scale up, increase the use of kangaroo care worldwide, because it pertains to all babies. And then, of course, at this next meeting, Bjorn Westrup's study with Bill and Melinda Gates is up for, the keynote address, because we want to hear all of that. I know that Erlandson is going to be presenting some more of her work with fathers. She started to get lots of serum measures off of fathers and their babies while the fathers are doing kangaroo care. I'm hoping to have the results of our neonatal abstinence study, how well the babies do, in severity is way down, severity of withdrawal when the mothers do it. And I can tell you, even if you give the mothers a pamphlet that says what you can do for your baby, they don't read it, they don't do it. And one of the biggest problems is that the nurses think they're doing things, or the mother says, oh yeah, I'm doing things. But when you really have somebody in the room observing, as we have had for 4 hours every day, no, they're not doing any. Our control group was, what were they doing from the booklet that are all given, and they're all watching TV. So they're not doing things. So the non-pharmacologic interventions are just generally not in use. And when you do have a group that does kangaroo care, they're very empowered by it. That's really wonderful thing. And we've had the mothers group, it's called Moms Too, ask us in the Cleveland and down in the Akron area to expand the kangaroo care program to these halfway houses where the mothers and their babies are discharged to before they let them out together back in their old environments in the civilian life. So I hope to have that data and run a workshop on kangaroo care for the full-term babies, because the International Network of Kangaroo Mother Care did not want to have full-term babies included. They thought it should just be for the preterm babies. And I said, no, all babies benefit from it. So now that's, we did have a workshop in Colombia, and this will be the second time we have a workshop group for full-term kangaroo care, which we call skin to skin as soon as it's a full-term healthy baby. And do something for SUPC, because the International Network wants the statement that I did for AWAN to be updated and consider the breadth of different countries for Inc. to support, and then World Health will be publishing that for us. So this is we're all into kangaroo care, people from all over the country, all over the world, people who are the heads of public health in their countries, and neonatologists and nurses who really want to know what they can do to make things better. It's really a delightful meeting, and you will get very little sleep, because we go from 8 in the morning to 8 or 9 at night if you get in and go to bed then. I always had meetings with other people for some articles we were working on.
Presentations are 10 minutes, one after the other. It's amazing. And the work that they do, and the very progressive. Spain, for example, they do ROP exams during kangaroo care. Is amazing. So more and more, more interventions are being done in kangaroo care. So I'm very, very proud to be able to present this work, present the Zaki-Zak, so all these interventions can be done safely in the United States and in the world. Basically, we sell everywhere.
And there's a registration cost. The highest we've ever paid for the 4 days was $300. And sometimes when we had it in the United States, nobody had to pay anything because the School of Nursing supported the whole conference.
In Canada too, right? It was not expensive. It was not expensive.
Yeah.
The expensive thing is the travel expenses.
And they feed us lunch, and sometimes we have the wonderful dinner party where
Yes.
and stuff. Oh yeah, that's lots of fun.
Every 2 years is in different places. So Canada,
Indonesia. We've been to Indonesia,
Rwanda, Colombia,
Scandinavia, United States, Italy. We've been to Italy twice.
Christy, yeah, that was really nice.
But the 25 meeting is definitely either going to be in China or Japan, because it's now the whole network, the Asian network of kangaroo care is going to do it. So.
The meeting in Spain is usually in the week before Thanksgiving. And the meeting in Spain is scheduled for 2023. Mm-hmm. But I'm not sure if they have changed the time. Yeah, Monica.
Okay.
Anything else?
I have to go. I need to get lunch before faculty meeting at 1.
Thank you so much. And I want to thank everyone that participated. We will send you the link so you can refer to it again. And we'll see you Friday again. If anybody wants to register, I think registration is still open for Friday. And I'm sure it's going to be a different session and just as amazing as this one.
And thank you for being the champions for Kangaroo Care. It's truly a very profound, awesome experience, and it will affect mothers and their babies for the rest of their lives. Thank you.
That's true. All right. Thanks.